To start, some of the patient history. This exam was performed on March 11th, 2025. This patient was an inpatient. The patient was 67 years old and was a male. He weighed 113 pounds. He was also 5'6". We did not have to use Definity for this exam, and it was a limited instead of a full because he had recently been seen in an outpatient setting, fortunately. So for that day, we only had to do a limited exam on him. Some of the indicators for the exam that day was endocarditis and bacteremia, suspected cardiac mass. This was the view from parasternal long, the deep imaging of it. You can see that there is a pretty hefty effusion there, which is why we were called in to take a look at it, get measurements of it, to make sure there wasn't any clots or anything hanging out inside of it. This was the first time I've seen it look so filled with, like there was something in it, but it wasn't a clot, thankfully. No clots were found in it. There was a large hypoechoic pericardial effusion identified in the parasternal long axis deep image. This finding emphasized the importance of the echo in diagnosing and assessing the pericardial effusion for a timely intervention is very important when there is any kind of fluid or mass or anything surrounding the heart that is detected quickly so that they can go in. More than likely, they will go in the cath lab and drain that fluid out. And just also keep a close eye on it. This patient will have to have follow-up visits just to make sure that they got it all, to make sure that there was no residual effects of the effusion. This is my colored pictures of the zoomed mitral valve and aortic valve. In the aortic valve, there was no significant AI noted, and the valves appeared slightly thickened, but they still opened well. And then next to it, we have the mitral valve, and there was also no significant mitral valve noted, and the leaflets were thin and pliable. So there wasn't much going on with those two valves. And then here's a close-up 2D of the tricuspid and pulmonic valves. You can take a look at those leaflets, the sizing there. And in this color, next slide, we have the colored image, which will show us that the leaflets were thickened slightly. They weren't crazy, but slightly thickened, and there was at least mild regurgitation. Something very useful that I've learned in my time in clinicals is if there is regurgitation in a valve, there's a reason for it. So your leaflets more than likely are not normal. Something is happening there, and it needs to be investigated thoroughly so that you can call things correctly. You don't want to put normal on a valve that's thickened and causing that regurgitation. And then in the pulmonic valve, there was a mild amount of PI present in the valve, and so that valve also needs to be interrogated thoroughly. Here's our pulmonic valve Doppler. It just helps us visualize that there's at least trace, and we call trace to mild PI for this valve. Doppler is really, really important because it can show us the magnitude of that regurgitation if there is any in a valve. Sometimes it shows us more than what color is showing us, and sometimes vice versa. Sometimes color shows us more and the Doppler doesn't show us, especially with those eccentric jets. Sometimes you just can't get your sample gate on it clearly, and so that is really helpful. Here we have a close-up of the aortic valve in short axis. We did call it tri-leaflet, and there was no AI noted in it. We didn't see anything. The leaflets were fine. They opened well. They weren't thickened. No calcification on them, so that was really good in his case. And then here we have the tricuspid valve in the parasternal short axis view, which we use to be able to interrogate that tricuspid regurgitation differently. It's really a great view to try and get that jet straight on with your sample gate, especially if it is an eccentric jet. Once again, you just want to try and interrogate that from any view that you can get it. One of my personal favorites that I've learned during clinicals is the Omaha view, which will take place in apicals. And it's when you get to that three-chamber view, you twist it a little bit more and you can pull that 4-chamber in, but flipped. And it's a really great view to be able to pull in tricuspid regurgitation specifically. But here again, you can just see that mild regurgitation was really well visualized and captured. Next, we have our mitral valve from the peristernal short axis view. It demonstrated that the valve leaflet was thickened, but there was no mitral regurgitation, thankfully. This view is great because in the peristernal long axis view, we didn't really visualize that well that those leaflets were thickened, as well as we did here in the short axis view. You can really see it when you're right on top of it with the probe, and it's a great view to be able to continue to thoroughly investigate the valve that you're looking at. And then again, the peristernal short axis view of the pulmonic valve. The pulmonic insufficiency was not well visualized from the short axis view. Sometimes those jets just aren't going to come in a certain view, but it is important to show your attempt and to continue to move around the body. Depending on the person, you might have to do breath exercises. You may have to reposition, try it supine, try it in any view, use all of the tools that you have to be able to pull it in as best as you possibly can. Unfortunately, today we just couldn't pull it in that short axis view. And then we move on to apicals. This is the apical 4-chamber view, and as you can see, the walls appear to be thickened. There's redundant chordae present, and it's important to note to the provider that you can see that you recognize that, and that it's not a clot. It's not something weird just hanging out in the ventricle. And then it also shows at least trace amounts of MR present in the valve. In the valve, flowing into the left atrium there and filling it up, giving it this really odd shape. And another look at it from apical 2-chamber. Again, since it's a limited exam, we didn't go through, or we didn't capture all of the things that we took a look at. If you are doing a limited exam, and you will then put your color gate, your color box over each valve to see if there's any regurgitation that wasn't noted in the previous exam, or anything that wasn't an indication for what we're looking for today. You look at it. If there's nothing there, you don't capture it at our facility. But again, this 2-chamber view just shows that regurgitation from a different angle. Then we move on to our apical 3-chamber and color over the mitral valve. Again, just continue to interrogate it and continue to try and visualize it as best as possible with that indication of bacteremia and cardiac mass. You just want to make sure that you clear that valve. And then our apical 5-chamber view. There was no AI seen in this view. I don't believe there was any seen in any view at all, but this one specifically, there is no AI. Again, that apical 4-chamber right side, to focus on that trace to mild tricuspid regurgitation that was noted. In other views, you want to make sure that you get a good signal through that, a good visualization of that regurgitation happening. So it's important to go back and make sure that that is noted. Then we have our peristernal long axis close-up of that pericardial effusion. That mainly was the finding, the critical finding for the exam that day. And thankfully we were able to get good views of it, able to get good imaging measurements of it. You want to make sure that there's nothing floating around, there's some color on it, make sure there's no mass in it, and Yeah, so we were able to send this off. They did end up taking him to the cath lab just to get a closer look at it, drain some of that fluid off of his heart, and he was able to get the help that he needs. Thank you for watching.